It's Jennifer. I'm here.
Well, hello, Jennifer.
How are you?
Good. How are you?
Doing well.
Okay, Miss Lisa, it looks like your waiting room is cleared. Eva is currently logging in. So you might want to give her just a moment to get on camera and microphone, but I will hand it over to you. You're muted, ma'am.
Sorry about that. So from what I can tell, it's just me, Jennifer, and Dr. Stone as far as the TAC members are concerned. Is that correct?
Yes, ma'am.
Okay. So Dee Polito, I know, had excused herself. Maybe we'll get some other.
That gives you a quorum, and I can let you know if April logs in.
Oh, okay. That's what I was just getting ready to see if I missed an email from her. Okay. All righty, so we'll go ahead and move on. Hello, everybody. Thank you for joining us today. It's a pleasure to be here and to see all of you. This month kind of crept up on us quick. I guess I'm sure everybody's been as busy as we've all been really busy, and the holidays are upon us, but our holiday season. So folks are busy. After today, our next meeting will be in December. So time has a way of moving on. The minutes from our last meeting, I am looking for approval from those. And Aaron, did we post those? Did you post those again?
Yes, ma'am. They got sent out. If you can give me a second, I can let you know what date.
Okay. I remember looking at them, but I don't remember.
They went out 8/22.
8/22. Okay. So if you haven't looked at them while we're talking, if you could take a look back on 8/22 and just take a peek there. I'm looking for approval of those minutes.
I'll make a motion to approve.
Wonderful. Thank you.
Jen, can you turn your camera on? My apologies.
No,
Thank you.
I always forget that too.
I know to make our vote.
Yeah. Okay. And Dr. Stone.
We may have to, I can't get my camera to turn on.
You
So
were
we may
on a
have to-
minute ago, but you were
I
frozen
know.
in time.
We can come back to the minutes if Dr. Stone's having some technical
Okay.
issues if you'd
All right.
like.
So when you can get your camera fixed, let us know, and we'll in the meantime we'll move on. We're looking at our old business. So just to review, with the end of the PH emergency, we'd like an update from the cabinet on Medicaid unwinding and how things are going. We had a lot of great presentations in August.
Hi, good afternoon. This is Veronica Judy Cecil, Senior Deputy Commissioner at Medicaid. Just wanted to highlight a couple of things. So we are now into our 6th month of renewals, the restart of renewals. I will say that a couple of things just to remind folks about. We had pushed a lot of cases to the sort of towards the end of our unwinding period, the cases that are involving children. The reason for that is we were implementing child continuous coverage, where if a child's determined eligible, they're granted that 12 months continuous coverage. And there are only a couple of reasons why someone may lose eligibility. A child may lose eligibility during that time, such as turning 19. So we do have a large number of cases now that are coming through the renewal process. But we have continued to implement a couple of different flexibilities to help us manage that workload and to assist to benefit members as they're navigating the process. For example, we just implemented extending anyone who has not responded to a notice for a month. So if somebody is coming up on their renewal date, let's say October 31st, and we've not received a response to a request for information or to the renewal packet that they're sent, we are allowed to go ahead and extend those folks for another month while we continue to do outreach to them to get them to provide that response to us. Obviously, our goal is to actually make that determination as to whether somebody is eligible or not. We do know that folks may not be responding because they know they're no longer eligible. Either their income has increased during the public health emergency and as we move through renewals. But what we do want to make sure is that they understand that they can get connected to other coverage, such as a qualified health plan on the Marketplace Connect. So just making sure people are staying covered, even if they're no longer Medicaid eligible. So we're seeing a large number of pending start to accumulate as a result of that. We are also, while we're doing most of the population an extension for a month, we are extending long-term care and 1915C members up to 2 months. So you may see that someone has a redetermination date of, say, September 30th, but we might give them an additional 2 months to get that response in, get that renewal packet in. So again, just trying to keep people covered as they're navigating that process of responding. And that, again, you know, on both sides, with giving members that additional time to get the necessary information to us, but also from a workload standpoint, you know, just making sure that we're processing those renewals. This is creating an issue on the application side with the increase in work on the renewal side. If there are new applications pending, you know, that's creating some backlog for our applications as well. Some of the things we're doing to try to overcome that, we are bringing on additional staff on a regular basis and training them up in different ways to help offset that workload to our DCVS eligibility workers, Department of Community-Based Services eligibility workers. So, you know, we're trying to manage the workload as best as possible. I think our biggest concern is just making sure that members are responding. If they do have something pending, Their coverage is extended until that get processed. So just encouraging folks to get that in by their renewal date. It gives them at least some coverage until that gets dealt with. There are, certain problems with certain cases, and we just continue to urge folks to escalate those to us. We work very well with the connectors, which are the individuals across the state who are either contracted or who volunteer and have been trained to assist members with their renewals. We have an escalation process through connectors and through insurance agents who can also now assist members with their renewals. So just asking, if somebody is having difficulty, to please escalate those cases up to us so that we can get them looked at and determine whether or not there's a system issue. We were hearing that individuals with pending documents were getting terminated and they shouldn't be. So we have to go in and make sure those cases are being extended as they're supposed to be. Just a reminder to providers, we understand you have a lot on your plate, but we really appreciate you all being a source of outreach to our members, checking that redetermination date in Kentucky Health Net because it's now available. When you have a member come in and if you know their renewal is current, so they have, let's say, an October 31st renewal date, or maybe they have a November 31st renewal date, having a conversation with them to make sure they understand that they may have to go through an active renewal. Not everyone has to. If we're able to go out and check the databases that are available to us, we can automatically redetermine somebody. So it's really the active individuals that we're most focused on. The only other thing to mention is that if somebody does come in and they have just been terminated because maybe they didn't respond to a notice, they do have up to 90 days to be reinstated. So if they can just reach out and provide that information to us, we can reinstate them with no gap in coverage. Just encourage, again, providers to help members understand that option's available to them. We have a new provider flyer out on our Unwinding website, and I'll be happy to put that into the chat, the link to that in the chat. Lots of provider resources out there, other stakeholder resources. Our next stakeholder meeting is next week, next Thursday. If you're unable to attend to a live presentation, we always record them and post them. So to go back and look at it, just for the most up-to-date information on what's going on with Unwinding. But happy to take any questions that anyone might have.
Well, first I want to comment that it seems very generous that we've automatically extended 1 month and then 2 months for long-term care. I mean, that's very generous and very flexible, considering to accolades to you all, the extremes you have gone to try to make sure that nobody was overlooked. I guess my question is, at what point is there a plan? Since you're also giving them 90 days to come back and get signed on, do we have a hard cutoff so that you can better address your backlog of folks that are trying to get on the program for the first time? And because I know that population-wise, I'm sure in Kentucky, but across the United States, we're seeing a lot of changes and a lot of influx and a lot of people applying for programs. And as we look at new business, that question is going to come up. I'm trying to make sure I'm formulating the question right. What is your plan moving forward? Is there a plan for a hard cutoff? Or, I mean, you all have been exceptional, I think, as far as accommodating folks.
Thank you. Yeah, thank you for that. Yeah, I mean, we have to do this within 12 months. So there is going to be eventually in April 2024, unless there's a change in state law, we're going to have a final hard stop for folks. That's going to happen. And again, the one thing that we're trying to do is continue to bring on staff and train current staff to be able to handle those redeterminations and processing those renewals and applications. So we really are hoping, based on the forecast that we're seeing, that's going to happen towards the end of the unwinding period, that we should have enough staff to try to handle that.
Wonderful. Well, again, thank you. I applaud the efforts that have gone on across the state. I'm impressed every time we meet. Dr. Stone, did you have a question?
Not a question. I was just going to comment again and just really say thanks for all the work that's going into this. On a firsthand personal experience, we had a daughter that we fostered for many years. We still consider ours, and she's grown, but our address is still listed for her, and she has WellCare as a secondary insurance. And I've gotten multiple calls looking for her, and I've just been so impressed that it's not just a one and done, and that I told her today, you've got to call them back. So anyway, I just wanted to say thank you for this work, because not all families across the country are experiencing that kind of caring. So thank you.
I really appreciate that. And we do have a very exhaustive outreach plan. Not only is the state working lists of people who have to take action, but our managed care organizations for their members are doing the same. So there's a lot of duplication, but we felt like it was necessary to make sure we can try to reach folks before that termination happens. That's obviously our goal.
Well, I applaud you.
This is Stuart on with WellCare real quick. All the MCOs, I'm sure, echo that DMS has done an outstanding job with this, and especially when you compare to other states, they really have. And also, Dr. Stone, yes, please call WellCare. Please have her call WellCare.
Thank you, Stuart.
Any other questions or comments on this topic? All right, thank you again for that update and report. Are there any updates on the immunization fee schedules? I can't talk today. I'm drinking coffee, but I still can't. Sorry. Anyone?
Hi, good afternoon. This is Erica Jones with the Division of Healthcare Policy.
Yes.
So could you remind me what the actual questions were regarding the immunization fee schedules?
Erica, I think it was just an update for the whole TAC. I know that you all recently looked at those schedules and changed them to update them to make sure that kids had access to vaccinations, and just wanted to be sure that that was shared with the TAG.
Yes, and I think the latest update has been the new COVID codes, and also adding RSV. It hasn't been added yet, but we are in the process of getting that added, and also doing the change orders to make sure as those claims come through that they are approved.
Okay. Any kind of estimate? I know just for hospital systems, they're struggling to get the new vaccine. I'm wondering if you have any intel on that. Does anybody? It's hard to make a schedule when you don't know when you're going to have the product. So I was just curious about that.
Exactly. We had a meeting with public health earlier today, and we were told that there hasn't been as many providers asking for the RSV for adults as they anticipated. But the campaigns are out there and they're strong for wanting to immunize adults with the RSV vaccine. So I anticipate that maybe getting a bit more intense as the colder weather comes in, when people are starting to get
when they start actually getting sick.
Mm-hmm. Yes.
Yeah. Okay.
But as of now, we haven't heard anything from any providers. any concerns from them and as far as getting the vaccine or needing to get the vaccine and haven't been able to.
Okay, all right, great, great. Thank you. Thank you very much. Any questions or comments on that before we move into new business? Okay, so we'll move on to our new business. Thank you all very much. Number one on the list is, are the challenges for rural Kentucky different than that in the more urban and heavily populated areas of the state?
This is Stewart again with WellCare. And is this directed at MCOs? I'm thinking.
Yes.
Okay, I do have, it's nothing flashy, but a couple slides I could share. Be glad to share.
Great, thank you.
Sure.
You're now a co-host, Stuart.
Thank you.
And as always, if you could email that to me after the meeting, that would be great.
Will do.
Thank you.
I'm trying to find, okay. All right. Do y'all see Kentucky urban rural comparison? The chart grid? Okay.
Yes, we do.
All right. So we have an awesome quality team, Christine Lewandowski, who I don't think is on the call today, created this, and this is Kentucky data right here. And I don't know if you all can, maybe I need to increase it a little bit. These are various kind of metrics related to social determinants of health and anything kind of, related to accessing health. And so it's like, poverty, income, internet, transportation. And so this is an urban versus rural breakdown. Like on that left column, when you see the three, there's the category. Then you have rural versus urban. And so this is for all of Kentucky. There's a couple of these categories that just have WellCare data, but this just shows you rural, urban Kentuckians. And so, for example, we've got red squares, not circles, socioeconomic vulnerability index. And so this is, I've got a little note there at the bottom. This addresses the percent in poverty, unemployment, educational level, linguistic isolation, how much income is spent on housing. And the higher the number, the more vulnerable. So you can see, and this is for Kentucky, in rural areas of Kentucky, 68.6 is the rating for that social vulnerability compared to 54 for urban. And then, the far right is the statewide average. So that's clearly higher for rural. Also just median family income. Rural, it's 56,000. In urban, it's, about 67,000. Percent of individuals over 25 with no high school diploma, it's roughly 19 for rural compared to 12 for urban. But what's kind of surprising is over on the right there, the food desert tracks. Rural, it's, right about 6%, but urban is almost 22%. So that, which indicates it's more challenging. There are more pockets in urban areas where getting food is a challenge than rural areas. And then further down, we got a couple of categories here with red squares. Average percent of households with no computer at all, 15.7% for rural, 9.5% in urban. Percentage of households without internet, 23.6% in urban, in rural, 15.5% in urban. And so obviously there are there are challenges in both areas, but they kind of differ. But we've particularly noticed, like, well, for WellCare, for example, we have 60% of our members are in a rural area, and Eastern Kentucky in particular. We've got 160 something thousand members, which is actually more than all the other plans combined in Eastern Kentucky. And so some of the challenges that we particularly see is, number one, the individuals tend to be, it's higher acuity, they tend to be sicker. So they got more health, multiple health conditions, health problems, and particularly in Eastern Kentucky, there is fewer specialists, different healthcare specialists, and there's some, particularly pediatric. There's some really statewide that is a challenge, like with pediatric specialists, but it's even more pronounced, when you get into Eastern Kentucky. And so, we address that. We do contract with, for example, all the border children's hospitals, and those usually have like a really robust network of the allied, the docs and nurses and allied professionals. So we contract with them to try to get that, to address that need. Also, telehealth is one thing. And kudos to DMS. They, way before even the COVID pandemic, DMS had very expansive coverage of telehealth. I mean, they were way in front of the rest of the country, really. And a lot of people didn't discover it until the COVID pandemic, but DMS already had a very expansive coverage, progressive coverage for telehealth, and has extended even more during the pandemic. So that's definitely helped. We've got 89 different provider types that I've looked at that we have paid a telehealth claim to, and it's over 12,000 distinct providers. So that's, one of the tools that we use. But there is a challenge as well, like our care management team tells us, with non-emergency transportation. And because one of the requirements with that is you have to demonstrate that you do not have access, that it's not available, transportation is not available. And so that's a little bit of a hurdle. For example, if the car is being worked on, the member has to get it basically an attestation from a mechanic, that it's being worked on. And one of the things our care managers, we do outreach to members who basically show up as being an owner. Like, for example, you've got a couple, maybe that split up. And so you got the individual still on the title to the car as a co-owner, but they don't live with the person anymore. And so that's actually one of the things our care management team does, is work with those individuals. They educate them how to go to the county clerk's office and get their name removed, so it's no longer showing that they are, a co-owner on a car. But, absolutely. I mean, you can see there are challenges in both areas, really, but definitely, that's just a few challenges that we see in the rural areas.
Thank you very much. That was very helpful. And you were talking about the pediatric difficulties, women's health in general, OBGYN, that continues to be a challenge, especially in rural areas. I know. One of the things that prompted that line of questioning for this group is concerns about changes in healthcare offerings across the state and what that'll mean for rural facilities. It poses a great deal of concern. I'm sure that's shared by everybody on this call, what that would mean, since a large portion of our state is rural. The impact could be devastating. And I think by the the information, the data you just had in front of us, I think you said 64%, I believe, of our state is considered rural. So the impact could be huge. Anyway, thank you very much. That was very informational.
Sure.
I appreciate that.
Sure.
Anybody with any comments about that?
This is Jennifer from Aetna. I think you'll get a consistent message across MCOs. I think our membership distribution is going to play into what our particular data looks like. But I think one of the things that was really interesting to us as we started looking at this rural versus urban challenge is what's the percentage of members who qualify, or percentage of our friends and neighbors in the Commonwealth who qualify for Medicaid by county, and looking at that distribution, because you'll begin to see that in those more rural eastern areas in particular, the percentage of those who are Medicaid recipients goes way up. So from if you're looking holistically, like you said, on the impact of any policy change or facility change or something that's going to impact facilities, it will likely disproportionately hit the members that we serve versus your commercial or Medicare, right? Because we're covering those lives. And I echo what Stuart said from a transportation challenge perspective. I think broadband access is also an issue in some of those areas,
Yeah.
which can hinder our ability to reach them with other avenues like telehealth. I would like to leave with this caveat too. One of the things that we have seen recently actually is counter to what we've been thinking from a rural urban perspective. We're looking at all of our quality measures with an equity lens now. So do we have demographics that are not seeking services at the same proportion in an urban area as they are in rural, or men versus women, or Black and brown versus white? And we're seeing that our men in urban areas who are Black or brown are not seeking care at the same rate as their counterparts in rural areas, or women. And particularly concerning to us is those who maybe have a history of substance use and the lack of follow-up that they're getting there. So that's something that I think I just want to challenge us as we're thinking rural urban. I don't want to forget about our friends in the urban areas, because there are challenges there too. And although the density and the population, the concentration, and the access is there, we do still have challenges that we're seeing in our data from an access perspective. So I just want to leave with that.
No, that's a very valid point. That's a very valid point. And we have spent some time at past meetings discussing that, and especially when you look at the Black and brown communities, a sense of distrust of healthcare institutions and what kind of an impact we can have as nurses on that. And one of the avenues we discussed as a team was getting to them when they're young. And instilling that trust of healthcare institutions in them, because historically there have been issues that we all, we have to own as a country. And how do we tackle that and overcome that? And I think that's part of what you see in that data. It's right there in front of them, but they have an inherent fear of going, and their loved ones, family members, friends, associates that share that same fear that they've come to accept culturally, if you will, as part of their environment. And how do we overcome that and combat that? And very valid point, very valid point.
And speaking from just an urban perspective, nursing perspective, in our district with about 100,000 students, very stark disparities in access to care for our Black and brown children, and for most significantly children living in poverty. And what we found internally in doing weekend events is that, parents that are working labor jobs that have to be there all day, the healthcare system just isn't necessarily set up to meet those needs of families with social determinant issues, which is why it makes engaging all the stakeholders that can help ensure access are able to do that and bill for those services. I just wanted to say we're fortunate we're implementing a new electronic health record, just to add to the discussion we're having, that will work with the managed care organizations. And so when parents opt into this system, when students have multiple visits to the school nurse, for example, or there's things built into the platform that will alert to their insurer. Again, parents have to opt in that they want to participate. But for example, a child with asthma that sees the school nurse several times in a week, that will trigger an alert to the managed care organization, so that a care coordinator can reach out to the family. Really with that goal of providing wraparound services for families, and ultimately helping ensure healthier kids, but also lower costs for their care.
Excellent. lot of proactive things. We have this same conversation with KNAC, the Kentucky Nurses Action Coalition. We have these same conversations about healthcare disparities and equities, and how do we reach these populations and encourage them to, you can put all the work you want to in developing programs if you can't get them into the system to engage with you. How do you get them to engage? Good conversation. Thank you. Anybody else have any thoughts they want to offer on that?
Yeah, this is Carrie with Humana. How are you doing?
Hi, good.
Hey, so some of the things that we've seen in the past is, especially with the rural areas, is transportation. Just trying to get good transportation to and from appointments. Another thing that we've seen in the past as well would be just access to food or healthy food. Another one would be with the children of making sure that they get the vaccine as well. Really pushing for those well care visits.
Excellent. Thank you. Anyone else?
Hi, this is Suzanne from United Healthcare. So I'd like to echo what I've heard about transportation, and this is both from a rural and urban standpoint. We have our member population in both areas. So we've got some in Eastern Kentucky and some of the rural parts of Western Kentucky. We have a concentration of members in and around the urban areas. And overall, we see that transportation is a bit of a challenge. As I think somebody was talking about, having ownership of a vehicle, maybe it's working, maybe it's not, or it's a partial ownership kind of situation. We've had similar types of challenges there, but not just that. We've had members who live on a bus line and have been told that they won't qualify for transportation because they're within walking distance of a bus stop. But unfortunately, our particular member is not capable of getting to that bus stop, whether that's because of challenges with mobility or because of their chronic condition, or maybe they don't feel safe going to that bus stop. So again, I think I just echo the transportation challenge. Getting folks to their appointments is the biggest challenge that we see across the board. And then as far as like food deserts, so I just want to speak to that a moment. I know that there is a program where there's, and I'm going to get this wrong probably, so I apologize, but I believe that, was it Norton's was doing a prescription food pantry? Does anybody recall hearing about this? Where they had an actual food pantry for members in this particular location, or maybe they're going to. I heard something about this recently, but if we think about the challenges that our members have with food and transportation, if we can get folks to healthcare, why not have access to other needs at that same location? So the idea of a food pantry being available for our Kentuckians, wherever they may be located, being able to access food and healthcare at the same time, I think would certainly be a wonderful approach. And if you think about it as an incentive to get care. So again, I think I read or heard about that. And I thought it was just such a wonderful idea of bringing needed services together. And maybe working with, like, I want to say they were working with Dare to Care. And I believe that's maybe they're working with it or discussing it. But again, just looking at thank you, Stuart. Of course.
You're welcome.
I appreciate it. Stuart knows all of this stuff. You're such a rock star. I love hearing you when you come on these meetings. He's got his slides and he's always got his stuff, and it's just so awesome. You
I had to
always
Google. Thank you, but I had to Google.
Oh, you did.
I
Okay.
cheated. Yes.
You cheated. All right. Well, hey, you Googled fast. So anyway, but again, what a wonderful idea to partner with a community-based organization to bring in needed services and offer healthcare. And so when we think about looking through an equity lens, and we know that there is fear and distrust of healthcare providers, being able to try to bridge the gap with some other needed services like basic needs, foods, or a clothes closet. Again, just, we have to figure out the transportation issue to get people there. But once they're there, being able to serve more than just one need was my thought. So.
And Carrie,
I was a pediatrician in that clinic until I stopped seeing patients, and it is wonderful, except I can tell you transportation is still a problem because a lot of patients could not bring the food home with them, because they had to go home on the bus, or they weren't sure of their ride. Yeah. So yes, it was wonderful, and we do partner with Dare to Care, but it's still got there's some logistics going on that's a barrier.
Yeah, I think transportation is just such a challenge, regardless of urban or rural. Yes, each area has their own challenges, but I say that transportation is one of the biggest ones across the state. So thank you.
At least from a pediatric perspective, Kentucky has established family resource use service centers who are addressing many of these needs for children, at least, because they submit data to the cabinet on the amount of kids that participate in backpack programs at the school, which means they're getting food sent home with them on a regular basis and on the weekends, because and the schools that have family resource centers have closed closets and have all those things. Now we just need to make sure that the healthcare is provided. And I would posit that yes, transportation is an issue across the state, but children living in poverty come to school. And so anything that we can do to support the delivery of services like we've done with family resource use service centers would go a long way in helping change the trajectory of health in Kentucky.
And meeting people where they're at. I think that's absolutely the right approach, is meeting people where that. If we continue to have the transportation problem and we're not able to solve it, it's a widespread problem. We have to meet people where they're at and go to them, mobile units and things like that. So yeah, absolutely.
I hate to say this, but I'm just going to say it. For the food pantry in the clinic, it is Dare to Care, but the food is things like fruit cocktail and heavy syrup and jarred tomato sauce with a lot of sugar in it. And so it's, in my opinion, it's not very healthy. And then we got fresh vegetables one week, and that we're so excited we got fresh vegetables, and they were beets, raw beets. And I don't know how many people on this call, think, oh, I really want to eat some raw beets today. And, and so for families that aren't used to cooking and having fresh vegetables, I would think that a beet is not the thing to give them. And so anyway, I just had a problem with that. And I think we have to offer good foods, but also healthy foods and foods that people are more likely to eat. And so not just any food should be in the food pantry.
Right, yeah. I like apples and oranges for kids. They love that stuff. Or maybe partner with some farms and, access they can give. I'm sure they do. I've heard of them doing that anyways. But yeah, definitely not beets. I can't see them liking that.
Yep, and it's Stephanie with Anthem. Can you guys hear me?
Yes.
Yes, sorry, I couldn't get off mute. Yes.
No worries. Sorry, I was muted on both my phone and the computer, so sorry about that. I just wanted to echo what everyone else is saying. It is, I know both rural and urban, but definitely in the rural areas. I know we find that, you know, they're due to most of the time lack of providers, especially specialty providers when you get into the maternal, and, you know, there's a lot of maternity deserts out there, so not a whole lot of OB providers. And then, so the providers that do exist in the rural areas, their appointments are scheduled very far out. You know, it may take you 3 or 4 months to get in to see a provider. So then you're back into the same transportation, you know, needs for the members, that they have to travel a little further to try to get in with a provider sooner. And, you know, so we do have an empowerment team, is what we call it, to work on the social determinants of health. And we have certified community health workers that address each of those issues, you know, transportation and food and clothing, employment, internet, cell phone. You know, we try to really work on, I think, you know, like the rest of the MCOs do, we try to look at where the needs are, child care and, you know, transportation, the food, and then really work our extra benefits, you know, our healthy rewards or our value added benefits around those, so that we can offer gas cards and those sorts of items that will really help our members get to these important, you know, appointments. Because if they, you know, if they can't get to their well visits and get vaccinated and to their OB appointments, you know, then, you know, we're going to have issues, you know, down the line. So, you know, anything we can do to, you know, I don't know if it's transportation, but maybe, you know, also getting more providers or working together to try to get more providers in those rural areas. Thank you.
Thank you. Anyone else? A lot of good dialogue today. Very appreciated. Okay. I'm going to turn my camera on. Dr. Stone, you're the last person. Are you okay to approve the minutes? I'm just going to backtrack for a second. Oh, you're muted.
If my camera's not off, I'm muted. Absolutely.
Okay, great. All right. Now back to really in closing is a homework assignment for some of you, if should you choose to accept it. And for our December meeting, we are requesting 5 to 10 minute presentations to include member incentive benefits that are available, how do members receive their benefits. There's one. And the other, the surge in immigration affecting the ability to provide services. And that one's me. And I'm curious because I'm watching the news, I'm looking at some of the programs regarding the surge in immigration and them coming into some of our cities, and the struggle that's going on trying to provide both healthcare and education. Those are the big two. And well, and housing. I mean, we've got a lot of them living on the streets now, and it's a struggle. A lot of the cities, the healthcare organizations, the MCOs are like, uncle, we don't know, we're overwhelmed. And I know that Kentucky is seeing some surge from that, nothing compared to like what we're seeing in Chicago, New York, California, Texas, all of those areas. It doesn't compare to that at this time, but I'm sure it's been impactful for you all overall. And our school systems are going to be greatly impacted. And my the ask here is, are we already thinking along those lines, kind of like proactively preparing for what we're going to do, especially considering our original conversation today about how your backlog is starting to occur. And this just adds to that. And I know hiring is part of that, but we're interested in some presentations from you all about what your plans are to try to manage that when it occurs, because it will occur. It will occur. So any questions about what we're asking? Everybody, we're good?
I think we're clear with the homework assignment. I think we are.
Yeah. But you got a whole month, 2 months. But
yes, we've got plenty. We appreciate that, Professor.
that little heads up. Okay. All right. Well, good.
And I would say from a Medicaid enrollment we're not seeing, we definitely track our enrollment on a weekly basis, and we've not seen a spike that would be related to this.
Okay, all
But
right.
certainly happy to come back in December and continue to monitor that and let you know if there's, any
Okay.
changes for the Medicaid program.
Okay, all right,
And,
great.
that might not necessarily mean that in the communities there aren't issues, but in terms of Medicaid enrollment, there still may not be an impact.
Okay, all right. Apples and oranges. Okay, all right, great. Thank you so much.
Welcome.
And that is all we have for our agenda today. Is there anything from the group or anything from the TAC members that are on the call that we didn't get around to today, or that's sorry, I am at work. And it's a hospital, if you couldn't tell. Is there anything else for the group that we want to bring up? No? Okay. Well, with that said, looks like we're able to adjourn a little early then. Can I have a motion from the TAC members to adjourn?
So move.
Okay, great. Jennifer, you
Lisa-
good with that?
Lisa,
Yes.
you didn't officially approve the minutes.
Oh,
You've got to call it
okay.
because they were so far apart. We have to have somebody, we got to go through the process again. My apologies.
Okay, so I am asking for approval of the minutes. Dr. Stone?
So move.
Okay. Ms. Wiseman, are you on here?
Yeah, I'll second.
Okay, great. So moved. Minutes approved.
Thank you, ladies.
And with that, we'll go ahead and motion to adjourn as well. I'll see you
Thanks,
all.
everyone.
Everyone have a great rest of Thursday.
Thank you. You too.
Thanks, everybody.
Thank you.
Bye-bye.